PCL injuries. PCL injuries are of two types. You can have a bony avulsion or you can have a ligament injury. Now PCL injuries lead to a posterior subluxation of the tibia and that leads to an anterior overload. So many of those patients who have a PCL injury will complain to you of anterior knee pain. This is very important, which we miss. Because the tibia subluxated posteriorly and the patient will have increased tibio-patellofemoral forces. So they will present to you with overload of the anterior compartment and condyle injuries on the patellotrochlear compartments. So this is one thing that you must remember, that these patients can present with the anterior overload phenomenon. Now PCL is a ligament which forms the stability or the base of the knee. So what happens is, if there is a PCL gone, the tibia subluxated posteriorly and all the other ligaments also become loose. So in a setting of a multi-ligament knee injury, it is always important to address the PCL ligament first as compared to other ligaments. So if you have a multi-ligament injury like PCL, ACL, MCL, LCL, then the first and the foremost ligament which is important is to do a PCL, because if you do the PCL, the knee will reduce. That means that on a natural position, if there is a PCL injury, the knee will be subluxated. Whereas if there is an MCL, LCL or ACL injury, the knee will not be subluxated. I hope I am clear. Yes. So if there is a patient who is coming to you in a normal natural position, if he has a PCL injury, the knee will be subluxated. Whereas if there is MCL injury, you need to do a valgus stress to get the MCL opening. If you need to do an anterior draw to make the difference feel. So in this, on a static position also it will become unstable. So if there is a multi-ligament injury, you have to address the PCL injury first. So if you have an avulsion, so even if there is a 1 mm step, it's an indication for surgery. Only those patients who are non-displaced fractures or less than 1 millimeters, only those will need a fixation by all patients who have more than 1 millimeter will need fixation, either arthroscopic or open, to reduce the knee into a proper position. Otherwise, it will be a subluxated knee. Now, what I do in avulsion is an arthroscopic fixation. So, what I do is I make two portals, pass the wire through the PCL and then do a pull-out fixation. You can do an anchor fixation also arthroscopically, or you can do a posterior approach and fix these fractures. Okay, but by and large, what I do is a arthroscopic fixation of the PCL avulsion fracture, and that you can see. PCL avulsion fractures, arthroscopic fixation is now the gold standard, and you can reduce these fractures very normally. If you talk about new advances, you can use an anchor fixation also in a double row fashion to fix it. Now coming to the ligament injury. Now ligament injury of the PCL usually can be from the femoral side, mid substance or tibial, but more commonly it is on the femoral side. So very rarely you can have a femoral peel-off lesion which you can repair like you repair a ACL femoral avulsion. So if supposedly this is your femur, and usually this is the attachment site of the PCL. PCL has got a broader attachment site as compared to ACL. The upper portion is the anterolateral ligament and the lower is the posteromedial. So AL bundle and EM bundle. Okay, AL and PM. AL is on the top, PM is on the bottom, and the ligament goes like this. Okay. Now this is the bundle which is the more important. So if you have to do a single bundle PCL, you have to reconstruct the anterolateral bundle. And many a times in PCL there is a ligament healing also. So sometimes it happens that everything is peeling off from the femur in acute scenarios. So what you can do is you can put anchors here and do a fixation directly. So if there is a femoral avulsion of the PCL, you can repair that directly. Then you have, if you have a chronic case, you will have an intact PCL which you can see, but it will be lax. So what we do is, we do stump preservation. So we preserve everything. We preserve the native PCL, whatever it is there, and we augment the ligament only. So we can do a single bundle AL ligament reconstruction or stump augmentation. So you preserve everything, preserve the stump, and okay. And usually double bundle PCL reconstruction is usually not required. A single bundle is usually sufficient. Although there is a debate going on, some people now suggest that you need to do a double bundle for PCL. Now double bundle for ACL is a failure. So far double bundle ACL is now not accepted and people don't suggest, because the PCL is a broader ligament. You have a very large insertion. But still it is not clear whether a double bundle is better or a single bundle is better. Bundle, stump preservation, PCL reconstruction, and usually I augment this by here. Now as far as the tibia is concerned, the most important thing is you need to go down. So you need to go minimum 10 to 15 mm down of the tibia for a proper angle and to prevent the killer turn. So supposedly if you make your tunnel here, then there will be very high chances of late laxity of the graft and residual posterior sag. So if you want to avoid that, try to make your drop side. So champagne drop is whenever you have a posterior tibia, it goes like this. There is a small drop like this, like a champagne drop, and you have to make your tibial tunnel as low as possible. And this is possible only if you make it under arthroscopic guidance, and usually I make two portals, high posteromedial and this is called as a low posteromedial. So these two are the portals which are the high posteromedial and the low posteromedial portals, which one will be a weaving portal and one will be the working portal, by which we can ascertain the low placement of the tibial tunnel in the PCL. So this is very important, that it should be as low as possible. So you make up your jig here, apply your jig in this position as low as possible, and this should be, the entry point should be at the champagne. The other thing is you need to clear this area. So what you need to do is you need to see through the high posteromedial portal and work from the low posteromedial portal. And the important thing is you have to place your camera in the monitor so that you can do it with the opposite side. So you will not have to send this side, you have to make it at this side, and then you have to, so same side of the patient you place the trolley. So you operate it from the other side, okay, and then you have to do it under vision and take it as a sleeve, so that like a peninsular sleeve you elevate it, and that way you clear this area and make this under guidance. Now your vessel is very close. Vessel is right here. So be on the bone always. Protection is very must. So there are three techniques of protection. One is you preserve it as a sleeve. Second is you need to do a flexion minimum of 90 degrees. And third thing, you can use protectors and dilators here. And there is one more technique in which so these are the things by which you can protect the vessel. So be very, very careful, be very, very gentle. There is a special stopper which is also available in some systems. So when you drill it, the stopper will be there, it will not be over drilling. So what you can do is you can mark it with a stopper, so it will not over drill. The stopper will mark it